Hello, everybody, and welcome to Ty and Sky's Health Pub. We are very excited today. We are going to be discussing HIV/AIDS with a wonderful guest that we have here, Dr. Mateo from Sanford Bismarck. He is an infectious disease consultant. So we're going to be just talking to him today about HIV/AIDS.
Welcome to the show.
Yes.
Glad to be here.
And I think kind of a way to start out this whole discussion on HIV/AIDS is to de-acronym the acronyms. So if we could just ask you, what is HIV? What is AIDS?
HIV is human immunodeficiency virus. AIDS stands for acquired immunodeficiency syndrome.
Okay.
And that terminology has been around for quite a while now. You can understand it's a mouthful to say, and that's why we go with the abbreviations.
Yeah. We got to make things a little bit easier to say, and sometimes, do you think that in this situation that the acronyms are definitely warranted if it's so long? Because I can't imagine be like, hey, by the way, you got this.
I think the thing to keep in mind is that folks sometimes will use those two terms synonymously. And to be precise, they're not quite the same. HIV in some ways refers to the virus that causes infection. And AIDS is a syndrome in which you have severe disease. But the infection and disease caused by HIV actually spans a whole spectrum. So when people first get infected, they might not necessarily know that they've been infected. Oftentimes the acute symptoms are very mild: rash, sore throat, maybe a little bit of a headache, maybe a little bit of fever. It doesn't really feel any different from a really bad cold. And then for the next 10 to 12 years, you're symptom-free. And that's the reason why infection can spread so easily. People feel entirely healthy, entirely well, but they are able to transmit infection. And it's only in the latter stages of the disease when you have a lot of signs and symptoms: sore throat, thrush, headaches, diarrhea, weight loss. Actually, AIDS, when it was first described in Africa, was called slim disease because people lost weight like crazy. And that's the part of the continuum that's called AIDS. And that's when we know, on average, the immune system is very weak. The HIV infection, the virus itself is multiplying like crazy in the body. It's overwhelming the immune system. And if you don't do anything about HIV, then you can easily live to be symptom-free for 10 to 12 years. If you don't do anything about AIDS, you're usually dead in 2 to 3 years.
So for HIV, you might actually you might have some common symptoms that you might mistake for something else initially.
Yeah, it sounds like the flu or a cold or anything else.
Right, and you could just go on for a long time and not recognize, oh, wow, I have this. And so, in this situation, it's not like is early detection just very difficult then for HIV?
It can be. It requires a certain amount of index of suspicion. But, if a patient comes to me, for example, and they tell me, look, doc, I've got this rash, and oh, by the way, this kind of developed 2 weeks after the condom broke or something like that. I'm going, ooh, that's a red flag right there to be testing specifically for HIV.
Okay. So kind of there are certain things for you as a provider that you're looking for in a patient coming to you telling you not only about their rash, right, but maybe also about sexual experiences in the past
risk
that helps
factors,
you.
Absolutely.
Okay.
So it's what it is that they do in terms of their sexual practice, what it is that they do in terms of their livelihood. There are folks out there who are commercial sex workers, mm-hmm, and then injection drug users but also, it turns out in this state, we have a fair number of folks who, having just recently moved to the state because they come from overseas, wind up going and hanging out with people of their community, the sort of citizens who come from their country of origin. And there you can have transmission within that small community and not necessarily know about it until they come up with signs or symptoms. I've had patients come in who find out that they're HIV positive because that's part of routine testing they do for pregnant women. And they get screened that way and I go, ooh, we have a new one here.
So sometimes for women, then I guess do you find that a lot of women don't recognize that they have it until they go in for that particular screening then for pregnancy?
Unless you're really paying close attention to those subtle signs and symptoms of acute infection, you can not easily tell that you are infected. And that's the hallmark of the infection. It has a way of sneaking into a population and spreading because there's a long latency. It's 10 to 12 years or so before, on average, before you start having any sort of trouble with it.
Yeah, I mean, that's an entire decade.
Yeah.
You can think about, that's like almost a third
And
of
you
my
would
life.
forget about like the initial symptoms too. Like I've never thought about, oh, remember that time 10 years ago when I had
exactly.
when I had like, like I barely remember going into the doctor 2 weeks ago, So, it's one of those things, that's wild.
Well, and kind of we talked a little bit about this, but I think we should dig in a little bit more. So you mentioned risk factors. Let's talk about risk factors for getting HIV.
The known risk factors include injection drug use, any sort of instance where you have exposure to blood or body fluids. So commercial sex workers, folks who have had blood transfusions in the distant past. And to be fair, you might have been told that the United States blood supply was secured from hepatitis C in 1992. The United States blood supply was secured from HIV in 1985. So if you had a blood transfusion before then, especially, for example, if you were hemophiliac, because there the risks for purified and collected blood transmitting HIV was way high.
Hemophilia, what?
Hemophilia A, hemophilia B, hemophiliacs.
What's it? What is a hemophiliac?
Oh, I'm sorry. So hemophiliacs are individuals who have a genetic disorder, by and large, in which their blood doesn't clot very well. So in order to get blood to clot, they don't suffer from bleeds and anemia. They wind up having to get these factors, these clotting factors. And in the past, we would have to purify whole batches of blood to get enough clotting factor to transfuse patients. But in the process of collecting blood from a variety of sources, that's how you really made all sorts of blood products HIV contaminated. So that end of things sort of got cleared up in 1985, and you really ought not to be having any further HIV transmission to the blood supply. Nowadays, of course, you can have HIV transmitted from mother to child, but there are ways of preventing that sort of situation with appropriate antiretroviral therapy. And then what I like to caution folks who travel overseas, for example, that our blood supply is safe here in the United States, but you go to places elsewhere, Africa, South America, Asia, you run into an accident and you get transfused with blood there, all bets are off.
Yeah, it's kind of scary to think that, like, say if you're traveling internationally and then like you might be like essentially like playing Russian roulette then, like say if you had to get a transfusion in some capacity.
I've heard of some sophisticated travelers who, if they know they're going to go on a overseas mission, lasting 2 or 3 months, they'll bank blood.
That's the most vampire thing I've ever heard of.
They will actually set aside their own blood to say, keep this frozen and stored, because if I'm ever going to run into trouble, get into a trauma situation, need a transfusion, you ship it over within 12 hours.
We need to get like a cryo suitcase or something and just like keep one pack. And I'm like, if anything happens to me, open this.
I feel like, though, if you were running that through TSA and they open your case and they would not let you
that
through.
would set off some alarms.
Yeah, that might set off some alarms right there in the airport.
Yeah.
You might have some questions and a very rough, like, full body pat down coming your way after them opening up that suitcase.
You probably have to sign so many documents just to get that out.
Like explain the situation. Yeah.
So what's going on here? You want your blood to go where for why?
Yeah. But when you think about it, like looking at it from a preventative standpoint, that really makes a lot of sense.
You do not get HIV from mosquito bites. You do not get it from sitting in the same seat or swimming in the same pool as someone. You don't get it from being in the same room. I mean, the methods of transmission are very well documented. It's close body contact, blood and body fluids. And so anything else out there is urban folklore.
So if I'm on the swim team, I'm safe.
Yeah.
Then
Okay.
okay.
Yeah.
Cool. I'm really happy about it. But if I'm in like in a close proximity, like this close, for example, right? Am I at danger? Like say if Ty here had HIV, would I be in danger here of that?
No.
Okay.
And I guess to kind of really hammer this point home, we did some cooking last night, came up with 12 mason jars full of body fluids.
Oof.
And what we would like to ask of you to do while we're talking about the topic of transmission is we'll set each one of these out, and I'd just like to have you go through and tell us which of these contain HIV, or which of these would have enough HIV for it to be transmissible if this came in contact with my blood, and which would not.
Yes.
So I'll kind of have Skylar maybe set them out. We'll have our side of the table. This will be stuff that can transmit HIV, body fluids that can transmit HIV. We can just take them out one at a time, maybe.
Okay.
And explain each one. And then Dr. Mateo will have your side of the table be all the liquids / semisolids that cannot transmit HIV.
All right.
Okay, so first off, we have lovely mucus.
Yep.
Where did you get this from?
We baked this.
That looks like a lot.
More than one person was used for the collection purposes.
Okay, I'll sort of
mucus.
arrange it sort of in stacks or piles, I should say.
Perfect.
Okay, so this end you said is where it's unlikely.
Unlikely. This end will be likely.
Yeah.
Your end will be unlikely.
Okay, all right. So we'll leave that there for now.
Okay, perfect. So we have that on the unlikely end.
All right. We have pus.
Wonderful, wonderful. We had to pop many pimples to get all of that.
That's a great prop right there. I'll leave that there.
All right. All right. And again, towards the end of the spectrum that is not likely to be as transmissible.
We also have earwax.
Earwax. That's gonna go over here.
So that's way far. That is way over in our non-transmissible end. All right.
All right, and next up we have feces.
Ooh, that's gonna be down here as well. So.
All right. So way towards the end of not containing HIV.
All right, and next up we have.
When in Rome.
That's true. When in Rome.
Yeah.
We have urine as well.
Yep. That's
You just pass it right on
sure.
over.
All right. Again, towards the end of non-transmissible.
And then also, of course, one of our favorites.
Tears, yeah.
The tears of our haters,
Yeah.
as they say. So these are tears.
Mm-hmm. Yep. We'll just stack them up over here.
Perfect.
I don't know if they'll stack up, but
Perfect.
All right. So right towards the non-transmissible end.
All right, and next up we actually have saliva.
Okay.
A little bit of bubbles there.
Put that over here.
All right.
All right, and then next up we have vaginal discharge.
Sure. That's going all the way to that end.
All right.
All right.
We'll put that way over here.
Yeah.
All right, and then next up we have semen.
So you want to put that right next to
Next to it.
Right next to vaginal fluid. So we have vaginal fluid and semen way over here on the HIV transmissible end of the spectrum.
All right.
We're getting down to it.
Next up we have vomit.
Yeah.
All right.
All right, and now we also have blood, of course, another thing.
Sure. All the way to the end there.
All right.
Yeah.
Blood is going on the very tip-top end of our transmissible end of this spectrum here.
And we also have sweat.
Okay. Goes up here.
Perfect. And
How's that look?
that's pretty
That's
beautiful.
the pyramid
actually.
right there.
And we do have a little bit of a lightning bonus round. So we have two fluids that we thought of since last night. So we have right here amniotic fluid. Very yellow, this amniotic fluid.
Boy. There I think there is a risk for transmission there, but it's hard for me to, I'll just kind of stick it in the middle there.
Okay, so we have amniotic fluid kind of right here in the middle ground. And the very last one we found an appropriate container for is breast milk.
Breast milk. There is a risk for transmission there, but it's really low. It was present before antiretroviral therapy came along. Now that it's got effective antiretroviral therapy, it's very low. So we'll go ahead and right around here.
Perfect.
Yeah.
So, towards our transmissible end of the spectrum, we have blood, vaginal discharge, and semen. And then kind of we'll call it still the transmissible end of the spectrum, but maybe towards the middle ground transmissible.
Correct.
We have breast milk and amniotic fluid. And then towards the non-transmissible end of the spectrum, we find vomit, pus, I think we got saliva, sweat, tears from our haters, mucus, urine, feces, and way on the end,
Earwax.
earwax. So let's talk about kind of this end of the spectrum, specifically semen, vaginal discharge, and blood. What routes can these body fluids infect a person with HIV? Like, for instance, if I would swallow any of these, would I be at risk for developing HIV versus other ways?
Right. I think the deal with swallowing is that you have to have whatever you swallow pass through the stomach. And by and large, a lot of these agents, whether it's infectious or not, do get destroyed by stomach acid as part of the digestion process. The risk is when whatever it is that you get exposed to bypasses all of that. So when you have blood through a shared needle, when you have blood, massive exposure through a transfusion, or when you have a blood exposure because you're an EMS worker and you're resuscitating somebody out in the field and they happen to be bleeding and squirting blood like crazy, and you get exposed to an eye splash because you're not wearing protective gear, or you happen to have small abrasions or cuts in the skin and you have splashes of blood that way. Absolutely. Semen and vaginal secretions, by and large, are sort of transmissible through sexual contact. And by there, I mean, it's not just vaginal intercourse, it's not just anal intercourse, but oral intercourse as well.
Okay, so they can be transmitted through oral intercourse as well.
Yeah.
Okay.
So essentially the factor that you have to keep in mind is whether the virus that's being transmitted is found in cells, lymphocytes, and macrophages that are contaminating semen and vaginal secretions. Of course, they're going to be there in blood. But also there's free-floating virus that's not associated with cells. And if you have viral intact virus detectable in those fluids, then that's going to be a way to transmit. The case in point is when we have a patient, for example, they're on treatment for HIV, their viral load, what it is that we test to see if there's virus detectable in the blood, is undetectable. We say, well, the medications are working well for you. The viral load is undetectable in the bloodstream when we do a blood test. You're tolerating the medication well and things are hunky-dory. But it turns out, and this is how we learn the hard way, those same individuals can still transmit HIV because the medications to treat HIV don't get into the prostatic fluid, don't get into the semen, don't get into the vaginal secretions. So there can still be sexual transmission of HIV despite having a blood level down to zero. And that says you still have to use barrier precautions and condoms and mouth dams and things like that to avoid transmission through these sexual fluids. The highlight, and this was something I think that was discovered in the first patient report, I think was in San Francisco. The source patient had undetectable viral load, was well controlled with antiretroviral therapy. The patient that got infected through sexual contact had drug-resistant virus. And it's because the virus in the patient who was taking the medication was susceptible in the bloodstream, but what was escaping through the semen was virus that was resistant to the medication. So you had virus transmitted that had resistance to the medication the patient was taking through this particular route. It's like how we figure, is there any other possible way transmission could have occurred? They've done the proper epidemiologic studies, case finding, background detective work, and this is how they figured out even though an individual has well-controlled HIV in the bloodstream, there's still a chance they can transmit because virus can be transmitted through these sexual body fluids.
And not to, I guess, just to jump in order of these presented, but I guess like in terms of, because we're talking a lot about like, say, these things, but what about of like saliva? Because I guess considering like, because a lot of people would group like kind of like similar bodily fluids to like vaginal discharge and semen, like, because it is something that's like formed kind of like a lot of people will draw that comparison of, okay, it's almost like somewhat a similar consistency. So like, why is it so different in that case?
Straight up saliva is just water and salt and so a smattering of proteins. That does not contain virus. However, it's also true that when you have a a lot of periodontal disease, a lot of dental disease, and you have a fair amount of bleeding, for example, inside the mouth, just because of dental decay. You can have bleeding after a dental procedure, flossing. If you've got blood admixed with saliva, then that's a potential source for transmission.
So kind of like if there's any lacerations or anything
absolutely.
in your mouth, so like any sort of cuts, or if you like had a tortilla chip and you like that stuff, like, you know, so that's interesting.
The question comes up from time to time is when we see patients who sustain injuries to their fist, because we're talking about somebody getting punched in the mouth. It's the teeth that sort of break the skin in a fist, and apart from the usual bacteria that's there in the mouth that can cause severe skin infection, bone infection, it's like, well, what about HIV risk transmission? If there's blood involved in that kind of sort of trauma, absolutely.
Wow. And kind of what we talked about throughout this discussion, you mentioned that even though we may not be able to detect an HIV load in the blood, there are other areas of the body where it can still be transmitted. So HIV can kind of find these other places to hide in the body? Is it kind of sequestered?
Absolutely.
Okay.
So the state of the art right now in terms of figuring out whether treatment is needed, whether therapy is working, is to do a blood test to find out the viral load, how much virus is floating around in the bloodstream. We don't typically sample tissue. So we're not going to be doing biopsies. We're not going to be obtaining a snippet of skin or liver or kidney or lymph node just to find out how much virus is there. But the general estimate is that the tissue load of virus is easily 10 to 100 times higher than what's detectable in the blood. And fact of the matter is, HIV is the kind of virus that integrates, which is to say it gets actually into the genetic composition of lymphocytes and macrophages. It integrates, it can lay low, it can hide, and anything that stimulates a lymphocyte can reactivate that virus to sort of escape from its hiding place and start multiplying and sort of spreading infection.
So can it kind of go dormant then in some
capacity? It can go dormant for many, many years. The concept of cure is hampered by the fact that the virus can become integrated into lymphocytes. So you can have a really reasonably intact immune system, you can have an undetectable viral load, but there are still cells within the body, long-lived lymphocytes that harbor the virus. And until you're able to pry the virus out of those cells and kill them, there's going to be reactivation of infection the moment you stop antiretroviral therapy. And some of these lymphocytes it can live for anywhere from 50 to 60 years.
Oh, wow. Well,
so we're talking about not only tissue compartments where potentially a virus can survive for long periods of time. The testes, the brain is an immunological privileged site, so that's one. But then also these lymphocytes that can circulate throughout the body, memory cells, long-lived. All of these are sanctuary sites where our current antiretroviral therapy can't quite reach. So until we're able to come up with an agent that forcibly evicts the virus and kill them, we're going to be having to require antiretroviral therapy for life.
Okay. And I guess to kind of dig down into some of the things we've been talking about, you mentioned lymphocytes and macrophages. Can we talk a little bit about what their purpose is in the body, what they do?
Lymphocytes are the cells in the body that are there to help patrol the body, figure out who's a foreigner, who's an invader. So they're there to help fend off infections from bacteria, viruses, fungi, mycobacteria. They're there to help protect you against the development of cancers.
So they're kind of like
tumors.
Gatekeepers then, huh?
Absolutely. They're patrol cells. And the thing is, there's a whole variety of lymphocytes. Some lymphocytes are there to produce antibodies. There are some lymphocytes that are there to kill tumor cells. There are sort of effector cells, killer cells. And then there are these memory cells that the fact of the matter is when you vaccinate somebody, for example, then you stimulate a subset of lymphocytes that are going to be primed to react to whatever you vaccinated against. You vaccinate against influenza, for example, and those lymphocytes are there, and the next time you get exposed to the same flu strain, the immune response is much more rapid. You don't get as sick. You don't have as many symptoms. You're able to shrug off the infection. You still get infected, but you don't get affected. You don't get sick from
So
it.
it's kind of like raising up the alert level then, like, you know, it's
Exactly.
all of a sudden
Exactly.
it's like, all right, we're on code orange, you know, it's like,
straight
you
to code red.
gotta get ready. It's code red. It's like, get ready for a fight, you know, that's really interesting.
Macrophages are the cells that are essentially there to clean up, sort of gobble up bacteria, destroy them, gobble up tumor cells, destroy them. And it's essentially a way to make sure that there's not too much garbage that accumulates in the body. They're there to clean up. So both of those cells can be targets for HIV. That's the most insidious thing about this virus. It actually targets the cells that helps you fend off other types of infections, complications, and malignancy. I like to say that HIV is a terrible disease because, number one, it makes you thin and lose weight. I mentioned before. It can oftentimes cause a diarrheal illness, which can be socially awkward for a fair number of people. It can infect the brain and cause dementia. It can weaken the immune system, so you wind up being a lot more prone to infections and malignancies. And lastly, because you're sick, you can't work, and makes you poor.
Is there any sort of, I guess following that line of thought that, that how much it truly affects someone, is there any sort of treatment, you already brought up some treatment in terms of treating in the blood, but is there any sort of treatment for the individual, or are there any sort of, what kind of help can someone expect if like you realize that you have HIV? So like, what is kind of the next step for an individual that becomes diagnosed with HIV?
The staging that we have is to make sure that they are not already dealing with complications. If they happen to have frequent bouts of pneumonia, we have to try and prevent that. If they have thrush or some other type of yeast infection, we have to either treat infection or come up with something to prevent complications along those lines. We have to see if there's already some sort of malignancy that they're dealing with, and things like anal cancer, cervical cancer, lymphomas, leukemias. All of these can be a lot more common in individuals with HIV and AIDS. So it's a matter of also figuring out if they've been vaccinated. It's helpful to prevent pneumonias by vaccinating against pneumonia. These individuals ought to be getting an annual flu shot. But there are other specific types of vaccinations that can be helpful. Hepatitis B vaccination, hepatitis A vaccination. If they're going to be traveling overseas, they need to be getting travel clinic vaccines. So it's a whole spectrum of things that we need to figure out, not only where the viral infection stands, not only where their immune system stands, but the sort of things that they need to do to prevent immediate complications. And then eventually they have to get started on antiretroviral therapy because that's what helps prevent later complications.
So I guess along the lines, when a lot of people when they become diagnosed with something, it's always like a major life-changing event for folks.
Sure.
In this case, is it all just is it all doom the whole time? Is it all doom and gloom, or is it possible for like folks to? Because I know that's like a common because we want to talk about I guess a little bit of the misconceptions about HIV. Because I know in terms of general information, sometimes it's kind of a scary topic for folks to interact with, because as soon as it's brought up, it's like, oh, I don't want to stay away.
So I'll first start off with the perspective that I know folks from overseas have. You have HIV infection or AIDS in Africa, South America, Asia, and for a lot of those folks, it's like a death sentence because they don't have the resources to be treating complications. They don't have the resources necessarily to be using widespread antiretroviral therapy. And 25 years ago, these folks were just sort of given a pat in the back. Go to your family, make sure they help you out with the last few days of your life, and that was it. The perspective that we have here in the United States has always been, let's go after this, let's be proactive, let's see what we can do to treat people. And with the development of antiretroviral therapy, that's actually come to be over the last 3 decades. When I got done with my fellowship training, I always thought that AIDS would be great to deal with because, it's a short-term relationship. And this was in 1993. 1996 is when a highly active antiretroviral therapy came along. We finally figured out that instead of using one or two agents, you ought to be combining 3 medications simultaneously. And that made the difference because, number one, it prevented complications. It prevented people from getting hospitalized. It prevented people from getting sick. They no longer died. They could stay in the community. They could keep working. They could earn a living, and they didn't have to cash in their life insurance policies. Since then, antiretroviral therapy has become so much simplified that instead of taking a salad bowl full of pills, it's now just 1 tablet a day. And it's gotten to the point where if you have effective antiretroviral therapy, a pill that works, taken once a day, no side effects, it's affordable, people can stay on it for years on end, the expected lifespan for effective and safe antiretroviral therapy is 50 years. So in other words, in the past, I'd have to couch my advice because if I told someone, oh yeah, you just got infected and you're 40 years old, and back then medications would be helpful for anywhere from 5 to 10 years, that would mean one thing. But if I told a 20-year-old that you just got infected and this is all we can offer, it's like, what am I going to do if all I can expect to do is live another 5 or 10 years? So it made a difference if you're 20 or 40 years old. Nowadays, it doesn't make a difference. No matter what age you get infected, we can provide you with medication, we can treat the infection, keep it fully suppressed, keep you healthy, and you can expect to live a normal lifespan.
Even though it kind of like it's a little bit good to know that, in terms of like, say if you did have it and you're like, oh, this is good, and like suddenly like it kind of eases it off a little bit. But, do you think that people still with the advancement of, say, medicine, do you feel that like some people are just like, oh, there's medicine for that, like, do you think that like, even though like with the seriousness of, say, this topic, does it change human behavior still? Or is it something like, do you think that there's been with the spread of HIV, do you think that it's just that the message itself is having difficulty in terms of translating to people? And if so, is there a particular reason why?
I think the level of concern was sky high when there were no effective treatments for it. And clearly the point that was hammered is if you can avoid it, if you can prevent it, if you can avoid getting infected to begin with, that's the best thing. The urgency of that message sort of tapered off a little bit when people figured out that drugs were available to keep the infection under control. Initially, there were a lot of side effects, but now with simpler regimens, highly effective regimens, rapidly effective regimens, safe, with few side effects, the public health message, I think, that to sort of still highlight prevention is the better thing has sort of eased off. In fact, the matter is, you've got a whole generation of younger individuals who are susceptible to HIV infection, have the right risk factors to do so. They look around at their peers, they look around at older individuals with HIV infection. They don't necessarily see that these folks are doing badly. They don't necessarily see all sorts of complications and the really severe opportunistic infections that, older generations might have gone through. So they say they think this is a manageable scenario. It's not the end of the world in case they get infected. But the fact of the matter is, this is maybe something that we can get away with here in the United States. You go anywhere else in the world, and that sort of situation doesn't hold true. The lifetime cost of antiretroviral therapy, for 50 years is still like $2,000 a month. And if it's not sustainable in terms of a healthcare infrastructure, it's not sustainable in terms of a society. And when you want to take a look at this globally, when you take a look at it as a country, it's still going to be so much more cost effective, so much more worthwhile to pursue prevention. If there's a way to stop this in its tracks, and that's the better way to go. The problem is what's there in terms of a prevention message, what's there in terms of the efforts to do so. It hasn't really quite made a dent in the 50,000 new cases that still come up every year. And we've known about that sort of rate for the last 10, 15 years or so. We've managed to not have patients die in the hospital. We've not managed patients not die at home. we've prevented all sorts of severe consequences. So we have a whole group of people out there that are HIV infected but are still able to thrive and do their thing in society. Now, is there a risk for transmission still? Sure, if you're not careful, if you're not taking the medication, and we talked about that earlier. And is there something that we can do to actually bend the curve and decrease the number of folks who still get infected every year? That's a more difficult proposition because you talk about folks who are here in the United States, born and raised, and that's certainly one source. But another source that we still have to come up to grips with are folks who are foreign born. They're coming in, and they're no longer prohibited from entering the United States, whether they have their HIV infection or not. And now you're starting to talk about cultural differences and how do you access those. The last thing I want to point out is that HIV is the kind of virus that finds a way to thrive in marginalized sections of society. So if you have injection drug users with HIV and you plug them into treatment for their addiction and for their infection, you're going to do okay. But you go to places like Russia, where an injection drug user is not medically treated but criminalized and imprisoned, and that subpopulation is going to have the HIV infection thrive within the prison system. If you have a commercial sex worker, and instead of giving them vocational training to get into a different line of work, you don't give them a proper protective advice to continue working as a commercial sex worker. If you wind up marginalizing them, then that's a segment of society, for example, in India or China, where HIV is going to survive. And so it's the same sort of deal in the United States. You know?
So it seems like it's a social economics issue as well.
Yeah, and it's I think that's a very, very important point that you drive home. The reality of things like offering needle exchanges for people to safely exchange their needles,
yes,
or like you mentioned, reaching out to these marginalized subpopulations, I think for a certain amount of people it seems counterintuitive or difficult to stomach. But as long as we kind of continue to just leave these people without any help, like you mentioned, the problem is just going to continue to happen, and HIV will continue to be a predator preying on these subpopulations.
And those solutions seem to have so much controversy surrounding them anyway. So like the needle exchange program has a lot of controversy around it, even though it is producing some successful results. And so
the latest case in point was in Indiana.
Oh.
And there it was not just HIV but also hepatitis C. That's where we saw where, you know, whatever public health structure they had in place clearly wasn't working, and they had to make some drastic changes, specifically with the needle exchange program as well.
And I guess that in terms of these type of we're going more into like, you know, more marginalized groups that are most at risk for HIV. And so it seems that, do you think that this comes down from an issue of education not being transferred, or because some would say, like, of course, you know, people suggest wearing condoms, and, you know, generally, like, there is some hesitation about, like, programs that give out free condoms and things of that nature, because the thing is, like, even if they're free, some people say people just still don't use them, or, you know, that there's not enough education at, say, even at our schools about general, like, sex ed education is lacking. Do you feel that that's the case in general with HIV, and that there's just not enough coverage of HIV in schools?
That definitely plays a role. There's a certain amount of pulling back from the public health message, a certain amount of downplay. And, admittedly, the urgency of the prevention message has always been there, but it's crowded out by a whole lot of other issues. The way to inform the population at risk is to start them early, to sort of emphasize there are a few simple things that you can do to prevent HIV infection. And fact of the matter is, people are able to learn. It's just not clear to me that that message is out there, is spread widely. Now, is public schools, is the school system the proper venue? They don't have home ec classes or health ed classes anymore.
I miss getting to go to like shop or cooking or like I didn't get really much of that into it, but I didn't pick up too much. I might remember a few things, but I know that like certain like small things like mitochondria is the powerhouse of the cell, for example, right? So
I don't have any strong feelings about how the changes should be affected and how the messaging should be done. But I think there is a point to emphasizing it more at younger ages, because then that's where you are really able to make an impact for the rest of a person's sort of interaction with society. So,
and I guess what can a person do to protect themselves and protect others from HIV transmission?
What's clear is effective is a barrier precautions. So condoms, mouth dams, anything that's there as a physical barrier. What's also available, and of course this is a message that a lot of folks would prefer to hear, is just straight up abstinence. That time and time again just runs up against human nature, and it's just not going to be all that effective.
Yeah.
What's available are medications to help prevent transmission. And over the last decade or so, a number of companies, of course, have done the research to see what works in countries other than the United States, what works well in the United States. And what's been approved, what clearly is effective, is oral medication, antiretroviral agents that can actually prevent transmission. And as long as a certain level of medication is in the bloodstream, you are protected whether you're having sexual exposure casually, frequently, or occasionally. And so to the extent that there is effective pre-exposure prophylaxis, we call that PrEP, pre-exposure prophylaxis. To the extent that that's available and effective, it's not free, but it is covered by insurance. It's a matter of letting folks know that this is available. We have to be checking certain blood tests to make sure it's going to be safe to administer. You have to be using it in a way that there's a protective level in the bloodstream. You can't be stopping it and starting it and taking it just sporadically. You have to go through a lot of these nuances, but the fact of the matter is it's effective and it's available, and so it should be highlighted and brought up as a sort of point of discussion. Now, are physicians and nurse practitioners and physician assistants necessarily aware that it's available? I don't think so. Are patients or folks who are at risk necessarily aware that that's available? I'm not so sure either. But there are networks, there are ways of disseminating information, and I think that's why we're all here.
Yeah, no, exactly. And I guess just as we kind of move more towards the finish, could you just tell us a little bit about the HIV testing and kind of what you recommend as far as that goes?
The test then involves a blood test where we check to see if there is antibody present. And antibody for HIV can be cross-reacting to a number of other viruses. There's HIV-1, there's HIV-2, HCLV-1, HCLV-2. A lot of the antibodies that are developed by the immune system against one will cross-react with the other viruses. A confirmatory test is typically done to see if it can be narrowed down to just HIV-1 or 2. And again, it's the typical standard blood test approach that's kind of holds up medical legally. But there are assays now where you can go ahead and take a swab of the mouth. You can go ahead and take a little drop of blood. And the rapid assays can actually give you a determination within 15 to 20 minutes.
That's really cool.
And it used to be that was sort of encouraged to be done in clinics, in outpatient settings, in emergency rooms. But the drawback has always been that you do a rapid test like that and you still need to do the blood test for confirmation. There are states now where you actually can do a rapid test one time and do a different kind of rapid test. They've got various kits out there. And if you have two rapid test results that are sort of congruent, they both point out a positive HIV result, that's enough to hold up. In the medical legal sense, that's enough to say you qualify for antiretroviral therapy. We can get you plugged into the healthcare system, and that's diagnostic right there. That's on the basis of testing for folks who are asymptomatic. If you have someone with clinical AIDS, a good clinician will take a look at that patient and say, you have HIV infection. It's like, we're going to be doing this blood test as a formality, but we already know what it is you got.
Yeah, based on your symptoms or the findings that they have on exam. Okay. And I guess, would you recommend, who would you recommend to receive this testing?
Well, there are sort of identified risk groups out there. But essentially, when you're concerned that you're feeling the least bit punk, have got these signs and symptoms after any sort of sexual contact, it'd be okay to sort of get tested. I mean, not just for sexually transmitted infections, but HIV as well. Oh. I like to say that, all of these pathogens travel with company. And the joke I used to have is that, what do you call someone with gonorrhea, syphilis, herpes, and HIV? We call them incurable romantics.
That one's pretty good.
Yeah,
that one's pretty good. Yeah, well, I think definitely, this has definitely been very insightful discussion so far. It's definitely I think there's a lot for us to still do towards HIV. I think that it's a progress thing. We got to set a better example for future generations coming forward, because like you said before, we kind of see the older folks now, dealing with it and think, oh, it's easy street, right? And we need to actually be mindful of that, growing up, even as for the next group as well.
And be mindful with some ideas that have maybe been more uncomfortable looking back in historically, as far as approaching this problem and helping those most marginalized in society that are greater or are affected by this disease in much greater numbers.
Gotta have that open communication. Mm-hmm. It's like trying to communicate with someone while refusing to say every other word. It's like, all right, and what word is he trying to get at? It's I don't know what the message is. So it's good for us to be able to be direct about some of the things in HIV. So thank you so much.
Yeah. Thank you, Dr. Mateo, for joining us. This was a great discussion. If you guys have any questions at all, feel free to leave them down in the comment section. You can subscribe to our YouTube page, like us on Facebook. You can find this podcast on sites like Stitcher, iTunes, Google Play, YouTube, and kind of all the other places you can find podcasts. So thank you, guys. Thanks for tuning in. Have a great day.
Have a good one.